Please stand by. Good day, everyone, and welcome to today's webcast, a review and comparison of different forms of age-related and inherited macular degenerations. During today's webcast, you can submit questions to the presenters. Please type your question into the question box under the Ask a Question tab on your screen and click Submit. If you require technical assistance during today's event, you can reference the help link at the top of your screen. Please note today's call will be recorded, and I'll be standing by should you need any assistance. It is now my pleasure to turn the conference over to Ben Shaberman of Foundation Fighting Blindness. Please go ahead.
Great. Thank you, and welcome, everyone. Glad you could join us for this continuing education webinar on the different forms of macular degeneration. As you heard, I'm Ben Shaberman. I'm Senior Director of Scientific Outreach at the Foundation Fighting Blindness. And along with my colleague, Michelle Glaze, she's Associate Director of Professional Outreach, we lead the Foundation's Professional Outreach Department. And in case you didn't know, the Foundation is the world's leading private funding source for retinal degenerative disease research to treat and cure conditions like retinitis pigmentosa, Stargardt disease, Usher syndrome, and AMD. And we are actually celebrating our 50th anniversary this year, so this is an exciting time for us. So our professional outreach department, Michelle and I, are educating eye care professionals throughout the U.S. about the many resources available to their retinal disease patients. And these resources include no-cost genetic testing, no-cost genetic counseling, a patient registry, and extensive information about emerging therapies and clinical trials. If you'd like more information about these resources for your patients, you can send an email to mglaze@fightingblindness.org. That's MGLAZE @fightingblindness.org. Or if you go to our website and click on genetic testing, select the For Eye Care Professionals tab, and you can get a lot more information there. And our website is fightingblindness.org. I'd like to thank Apellis Pharmaceuticals for providing an educational grant for this course. And just a housekeeping note, make sure you take the test at the end so you can receive your credit. And while you can submit questions, we're not going to have time today. We have a packed presentation, but we will get to your questions after this webinar at a later date. So now it is my pleasure to introduce Dr. Zarbin. He serves as chair of the Institute of Ophthalmology and Visual Science at Rutgers, New Jersey Medical School, and is a vice chair of the Scientific Advisory Board of the Foundation Fighting Blindness. He earned his undergraduate degree from Dartmouth and MD and PhDs from Johns Hopkins. He's co-authored 211 peer-reviewed scientific publications, 123 book chapters, 28 reviews and editorials, and 38 reports. He's the recipient of numerous awards, including a Life Achievement Honor in 2018 from the American Academy of Ophthalmology. So now it is my pleasure to welcome Dr. Marco Zarbin.
Thank you, Ben. As Ben mentioned, I'm going to speak about age-related macular degeneration mostly, and at the end, we'll briefly go over some mimicking conditions. These are my disclosures. They're all relevant in some way to today's talk. With regard to AMD, I'll talk about the overlap between aging and AMD, but then focus on geographic atrophy and choroidal neovascularization. Then I'm going to mention some toxic maculopathies that can mimic different stages of AMD. And then finally, some inherited maculopathies that can mimic some different stages of AMD in some respects. As you probably all know, AMD is characterized by the accumulation of membranous debris on both sides of the RPE basement membrane, with clinical manifestations of drusen, RPE, photoreceptor, and choriocapillaris atrophy, pigment epithelial detachment, and choroidal new vessel formation. In the vast majority of patients, the onset is after age 50, and it is the leading cause of blindness in the U.S. About 30% of people over the age of 74 have some degree of AMD fundoscopically. Now, aging and AMD do share some overlap characteristics. For example, thickening of Bruch's membrane, say with collagen and proteoglycans. One of the more unique features of thickening in AMD is basal linear deposit, shown by the red arrow. They also both exhibit protein cross-linking and non-collagenous protein deposition. But in AMD, you'll see things like C3A in these hard and soft grooves in A and C, and C5A in hard and soft grooves in E and F. And these are anaphylotoxins in the complement system. Also, both conditions are associated with lipid deposition in Bruch's membrane. Here you can see the cholesterol esters accumulating in drusen. But if you look carefully in the dark field, the white arrows are pointing to a thin layer of lipid accumulation in the intercollagenous layer of Bruch's membrane. And then they also can have advanced glycation end product deposition in Bruch's membrane. And for cells that have RAGE receptors, like the RPE cells, advanced glycation end products are a death signal. So if we compare Bruch's membrane in a 10 versus a 91-year-old, here we're looking down through a crack in the RPE basement membrane of both individuals. And in the 10-year-old, we can see the collagen fibers of the intercollagenous layer with basically a lot of space between them. But in the 91-year-old, what you see is dense material accumulation in the spaces. And this is due to lipidization of Bruch's membrane and also protein deposition. And obviously, it's associated with a compromise of the permeability properties of Bruch's membrane. This is what basal laminar deposit looks like ultrastructurally. It's an accumulation of material between the RP basement membrane and the RP plasma membrane. It comprises mostly wide-space collagen with some coated and uncoated vesicles and laminin and fibronectin. This is an aging change and not unique to AMD. Basal linear deposit, on the other hand, is located between the RP basement membrane and the intercollagenous layer. In fact, it really impregnates the collagenous layers of Bruch's membrane. And it is more specific, much more specific for AMD, and consists mostly of coated and uncoated vesicular material. Now, as part of geographic atrophy biology, but also to some degree as part of aging, there's a decrease in the choriocapillaris density. And what we see with aging is a progressive decrease in the thickness of the choroid from around 200 microns at birth to around 80 microns by age 90. In association with this is a decrease in the choriocapillaris density and lumen diameter, and an increase in the width of the intercapillary pillars. And probably this is at least in part due to the decrease in the RPE density as we age, which is shown in the graph on the right. Remember that the RPE cells produce vascular endothelial growth factor, which is important for the constitutive maintenance of choriocapillaris anatomy and physiology. And furthermore, in AMDIs, it's well documented that there is a decrease in choroidal blood flow in patients with dry AMD that's greater than in age-matched controls. So this aging change seems to be exacerbated in people with AMD. Here we can actually see the histology of the choriocapillaris in an aged human eye. This is an 87-year-old donor. The top rows show the clinical and then the postmortem photographs. The bottom rows show en face images of the choriocapillaris, and you can see, that the choriocapillaris is normal. And actually, if you look in panel F, it's a sinusoid. That's the normal anatomy of the choriocapillaris. But if we contrast that with the appearance of an 86-year-old woman who has early AMD, what we can see here is soft drusen, and we can also see pigmentary changes. But if we look under the macula, what we'll see is that there's a decreased capillary density under the fovea, and those asterisks point out areas where there are simply no choriocapillaries. And we contrast that to the parafoveal region where we have a normal capillary density. What's really interesting is that if you look at the edge of these areas of choriocapillaris dropout, you can see buds of neovascularization, which really suggests that choroidal neovascularization is a homeostatic response to choroidal ischemia. And this is an important change, which we'll talk a little bit more about. Inflammation, chronic inflammation in RPE Brooks membrane and the choroid is an important part of AMD pathophysiology. For example, drusen contain activated components of the complement cascade. They have complement receptor 1, a number of complement factors. Drusen also contain amyloid beta peptide, which also can induce inflammation. We can also see inflammatory cells in RP Brooks membrane. For example, here's a dendritic cell staged with HLA-DR and another with CD68, not only within Brooks membrane, but also involving a drusen. There are, as I just mentioned, bioactive fragments of complement that are present in drusen. And this is an important finding because it may explain something that's been noted for a long time, which is that confluent soft drusen are a biomarker for an increased risk for choroidal neovascularization. It turns out that C3A and C5A increase VEGF expression in our PE cells, and that's why we might expect those areas to be the ones that develop choroidal neovascularization. So the pro-inflammatory molecules create the setup for chronic inflammation at the RP Brooks membrane choroid complex, which I think account for many of the features of late AMD. Now, as you probably all know, complement mutations are very important in the pathophysiology of age-related macular degeneration. Just to remind you, there are actually 4 major activation pathways. Not shown here is the fibrinolytic activated extrinsic pathway. But the classical pathway is activated by antigen-antibody complexes, the lectin pathway by microbial surfaces, and the alternative pathway not only by foreign surfaces, but most importantly, it undergoes spontaneous activation. In other words, it's always chronically activated. And this is important because it means that tissue surfaces have to express intrinsic and surface-bound proteins that modulate the ongoing activation of the alternative pathway. Otherwise, the alternative pathway would literally kill us. So the activation of the complement system is obviously important for our survival, but if it is excessive, if it's not adequately regulated, it can lead to disease. For example, C3 class glomerulonephritis is due to abnormal activation of the complement pathway due to complement factor H mutations. Now, and mutations in a number of components of the complement system have been linked to an increased risk of AMD, and these are circled in green. But the key thing in this picture is that regardless of which pathway is activated, all activation pathways lead to the hydrolysis of complement factor C3. In fact, if you just look at variation in complement factor H, C2, and complement factor B, you can predict the clinical outcome in 74% of AMD cases. And just to remind you, complement factor H modulates C3 hydrolysis, and C2 and complement factor B modulate C3 convertase. When C3 is split, you create C3A, which is an anaphylatoxin, and C3B, which mediates the hydrolysis of complement factor C5 into C5A, also an anaphylatoxin, and C5B, which leads to the formation of the membrane attack complex. Remember, that complex creates pores in the cell membrane, and if enough of those pores form, the cell will die from osmotic shock. In fact, we're always making those pores in our surface, but we don't allow too many to accumulate because we can absorb them with endocytosis. So if the rate of pore formation is too high or the rate of endocytosis is too low, the cell will die. Well, here's showing the histology of the distribution of factor H. You can see it's in the inner choroid and Brooks membrane. And C3 confined primarily to inner choroid and Brooks membrane, but also present in some drusen. Here we can see factor B, which has a more diffuse distribution in the outer and inner choroid as well as Brooks membrane. And also we can see on the right in red membrane attack complex as a part of a drusen and an adjacent RPE cell. Here we can see membrane attack complex literally surrounding the choriocapillary endothelial cells. And then C5 distribution in some hard drusen, is densely deposited in basal linear deposit. And on the right, we can see in blue membrane attack complex associated with a dying RPE cell in an AMDI, and also densely deposited in a soft drus. Well, C5a and C3a mediate the activation of what's known as the inflammasome. And I want to take a minute to go through this because it's important to understand how certain drugs are now being developed. So C5a binds to the receptor on the surface of an RPE cell, and it initiates the first step in inflammasome priming, the priming step, which leads to the activation of NF-kappa B, which leads to a change in DNA synthesis with production of molecules called NLRP3, interleukin 1 beta and 18, actually the proform of those molecules, as well as procaspase 1. Then, if there is these three elements just sort of sit in the cytoplasm and nothing happens unless there's a second signal to initiate inflammasome assembly. And the inflammasome assembly might be stimulated by reactive oxygen species in the mitochondria, or by cathepsin release from the lysosomes, or by C3a binding to its surface receptor, working through a purinergic receptor known as P2X7. And once you get the second signal, you get the inflammasome assembly. And this is just a macromolecular complex comprising NLRP3, procaspase 1, and ASC. And what it does is it creates an active caspase 1 molecule that leads to the activation of interleukin 1 beta and interleukin 18. And these inflammatory cytokines lead to cell death through a process called pyroptosis. And you're probably all familiar with apoptosis, which is a form of cell death where the cell membrane remains intact and these membrane-encapsulated residua inside the dead cell all get phagocytized and eliminated quietly. But with pyroptosis, the cell membrane is lysed, and the inflammatory cytokines are released into the adjacent milieu, and they initiate the death of the adjacent cells. So if you think about how geographic atrophy spreads in a kind of contiguous manner, you can sort of intuitively imagine that pyroptosis might be an important process in the pathophysiology of geographic atrophy. Well, actually, if you look at postmortem eyes with geographic atrophy, you do see increased deposition of interleukin 1 beta in the RP and Brooks membrane compared to controls, as well as increased deposition of interleukin 18 in the RPE compared to controls. Well, the changes in the choroid capillaris and the activation of the complement system lead to an increase in the production of something called alu-RNA in the RPE cells, which is a non-coding RNA that initiates the synthesis of alu-cDNA. And alu-cDNA initiates the assembly of the NLRP3 inflammasome also. And as I've just mentioned, this inflammasome leads to RP and photoreceptor death and choroid capillary damage, and it also leads to aberrant neovascularization. As I'm going to mention in a little while, it turns out that nucleoside reverse transcriptase inhibitors can actually block this mechanism of inflammasome assembly and activation. Now, regarding the clinical findings in geographic atrophy, I think everyone recognizes that Northern Europeans have about a 10-fold higher risk of developing geographic atrophy compared to patients of other ethnic backgrounds. And about 20% of the legally blind AMD patients in the U.S. are blind due to geographic atrophy. Typically, the areas of GA appear extrafoveal and progress into the fovea, but even before they involve the foveal center, vision's affected because it's difficult for people to read an entire word, for example. Also, their contrast sensitivity and their dark adaptation is compromised. Of course, once the center of the fovea is involved, then you have profound visual loss. Now, this process of going from extrafoveal gradually to enveloping the fovea, it takes a median time of about 2.5 years. And as that process progresses, you go from, vision maybe in the 2020 to 2030 range down to 2400, or in some cases even finger counting. What's interesting is that there's tremendous anatomic symmetry between the right and left eyes with regard to the anatomic distribution of geographic atrophy with a correlation coefficient of 0.82. But in contrast, there is very weak symmetry regarding the visual acuity of two eyes with a correlation of 0.04. But I want to point out that this lack of symmetry in visual acuity due to minor differences in foveal involvement is only evident at relatively early time points. Here, this graph only goes out to 2 years. If we were looking over a period of 8 years, what we would see is that gradually there is tremendous similarity also in the visual acuity outcomes. Now, there are different ways of classifying the geographic atrophy, and the CAM study group has developed the following classification that I want to mention. The first important point is that OCT is the reference standard, not fundus autofluorescence, not infrared reflectance, color imaging, or fluorescein angiography. And the reason is you can have photoreceptor atrophy without RPE atrophy, and the atrophy can evolve through different stages. In fact, when you have complete RPE and outer retinal atrophy, that's called C-RORA. Incomplete RPE and outer retinal atrophy is I-RORA. Complete outer retinal atrophy is C-ORA, and incomplete outer retinal atrophy is I-ORA. For C-RORA, you have to have a hypertransmission region of at least 250 microns in diameter with a corresponding zone of attenuation of the RPE and overlying photoreceptor degeneration, and no evidence of an RPE tear. The pictures on the top show the OCT images that correspond to each of the different kinds of atrophy, and the pictures on the bottom show the corresponding histology. So with C-RORA, we have a hypertransmission defect of at least 250 microns wide, and correspondingly, we see an area that lacks photoreceptor nuclei, lacks RPE, and subjacent choriocapillaris. For I-RORA, we see a smaller area with a transmission defect, and anatomy, histologically, it looks identical, except it's much less than 250 microns in diameter. For C-ORA, what we see on the OCT is an intact RPE monolayer, but no evidence of an ellipsoid signal, which is the signal due to the inner segment portion of the photoreceptor. And histologically, you see the RPE cells, but very few viable photoreceptors. And then for I-ORA, the little white arrows are pointing out regions where the ellipsoid signal is intact, so we know there's some intact photoreceptors here. But when we look at the histology, we see clear thinning of the outer nuclear layer, but with an intact RPE monolayer. Now, histologically, what atrophy looks like is illustrated here at the level of the choriocapillaris. This is a woman with geographic atrophy, and if we look under the macula at the en-face image of the choriocapillaris, we'll see loss of capillary channels, thinning of the capillary lumina. And this is true not only in the center of the macula, it's also true at the edge of the area of atrophy. And if we do some quantitative work, what we could show is that outside the macular area, 82% of the vascular area, 82% of the region is covered by choriocapillaries that have an average diameter of around 29 microns. Actually, 20 microns, that's a typographical error. But under the macula, only 38% of the area is covered by choriocapillaries. So we've lost a lot of vessels, and they are very thin. There's a 9-micron capillary diameter. Histologically, at the border zone, we see the somewhat atrophic RPE at the edge, and then we see also the degenerate choriocapillaris. Note that there is no blood column in some of these choriocapillaries because the lumen are closed. And in the area of atrophy, there's no RPE or choriocapillaris. If we look ultrastructurally, the choriocapillaries in the border zone show vacuolization, and in the area of atrophy, there's collapse of the lumen and multilayering of the RPE basement membrane. Now, clinically, we recognize atrophy in some different scenarios. There's outer retinal atrophy, which is associated with reticular pseudodrusen, and this happens to be associated with a particular type of choroidal neovascularization known as retinal angiomatous proliferation, or RAP. Then there's more classic geographic atrophy, which can be associated with basal linear deposit, and this is more typically associated with what's known as type 1 choroidal new vessels that are growing between the RPE basement membrane and the intercollagenous Blair-Brooks membrane. This type of atrophy is also associated with flattening of pigment epithelial attachments. And then finally, there's the atrophy that's associated with the maturation of choroidal new vessels. So these are the three different clinical scenarios. Here's outer retinal atrophy associated with regression of subretinal drusenoid deposits. You can see the deposits at t equals 0, and then they're gone by 55 months. And if we did an OCT in this region, we'd see that the outer nuclear layer is thin, and the subjacent choroid also would be thin. And here's what these deposits look like ultrastructurally. The subretinal drusenoid deposits accumulate between the photoreceptors and the RPE, and we can see apical villus processes of the RPE seemingly trying to engulf this material. Under higher magnification, you can see the deposit and the apical villus processes and subjacent basal laminar deposit. Typically, the subretinal drusenoid deposits will accumulate in a parafoveal region, and if we look carefully, the photoreceptor outer segments are usually quite abnormal over these deposits, which accounts for the visual symptoms with which they are associated. If we look ultrastructurally, the subretinal drusenoid deposits don't look exactly like basal linear deposit. They have these membranous whorls as well as globular proteins, whereas, as you know, the basal linear deposits have vesicular and granular material as well as some membranous debris. Where the difference is more evident is if we look immunohistochemically. The subretinal drusenoid deposits have no esterified cholesterol, whereas the soft drusen have lots of esterified cholesterol. And in contrast, the subretinal drusenoid deposits have lots of unesterified cholesterol, pointed out by those orange arrowheads, as do the soft drusen in their basal linear deposits. Here's an example of thinning of the outer nuclear layer associated with regression of the subretinal drusenoid deposits. You can just barely make out these subretinal deposits with the arrow that I'm moving around. And by 63 months later, you can see that that dark outer nuclear layer has become quite thin. Those little deposits are no longer evident. And if you look carefully, you'll see that the choroid is actually also somewhat thinner. Now, with regard to the flattening of drusenoid pigment epithelial attachments, it turns out that the outer segment length of the photoreceptors is decreased in areas where the RPE are elevated. So here we see an area of RPE elevation, which is indicated on the y-axis and by this red arrow. And if we measure the length of the outer segments in this region, they're very short. Right next to it, we see an area where the RPE are flat against Brooks membrane, and the outer segments are much longer. Not surprisingly, if we look at changes in retinal sensitivity with the ellipsoid, as the ellipsoid signal goes away, retinal sensitivity goes down because it's a marker for loss of photoreceptors. Similarly, as we look at increased RP elevation, we see retinal sensitivity go down because that's a marker for shorter outer segments. Here we can see one of the earliest evidence of geographic atrophy. This would probably qualify as incomplete RPE and outer retinal atrophy. You can see loss of the outer nuclear layer centrally in an area less than 250 microns in diameter, necrosis of the subjacent RPE. We can also see discontinuity of the external limiting membrane, which is just a heterotypic junctional complex between the Macular cells and the inner segment of the photoreceptors. There's subjacent basal linear deposit and obvious collapse of the choriocapillaris. Here's an area where there's more profound atrophy. We're near the border zone, so you can see some multilayering at the RPE, and more centrally, you see residual basal laminar deposit. Interestingly enough, basal linear deposit goes away in areas of atrophy over time, but the basal laminar deposit never does. You can see, of course, loss of the choriocapillaris, and more peripherally, you see some residual cone cell bodies. So there isn't complete photoreceptor atrophy in this region. Now, Dr. Starks described very nicely what happens at the border zone, so I'll just read it for you. He said, in incipient atrophy and at the junctional zone, the drusen commence to regress. But before they do, the RPE elaborates flocculent basal laminar deposit, and mineralization can develop in the drus. And then in the area of atrophy, the drusen are replaced by cell processes, collagen fibers, and calcium. So let me illustrate some of these findings now. Here is a large drus And if we look with fundus autofluorescence, you can see there's a faint ring of hyperfluorescence around its base. And if we look 30 months later, it's become calcified. And in association with that, there's loss of the fundus autofluorescence because there's no more RPE there. Here we can see what the calcified drusen would look like on OCT. They are highly reflective, and they cast shadows, as you might expect. And here we can see the calcified drusen histologically, where the calcium stained with a Bancasa stain in the soft druse, and also there's calcium deposition in the subjacent Brooks membrane, just as Dr. Sark said. The junctional zone histology is kind of interesting. It turns out this multi-layering of the RPE in the junctional zone, as I'll show you in a minute, is really what accounts for most of the increased fundus autofluorescence that we see at the border zone of geographic atrophy. Once again, you can also see there are substantial numbers of viable photoreceptors in this area, although they lack outer and inner segments, so they're dysfunctional, although they're alive. I think it's instructive to compare the junctional zone histology to what we can actually see clinically on the OCT. So in the area of atrophy, you see the loss of the photoreceptor, the RPE, the choroid capillaris. You also see this zone of hypertransmission that I've mentioned before. The margin of the ellipsoid disruption can be seen on the OCT. And more centrally, you see the margin of the external limiting membrane disruption on the OCT, not just on the ultrastructure. In this area, we will also see the margin of RPE loss and the margin of choroidal hyperreflectivity, as I've mentioned. The asterisk is just to emphasize once again that it's the area of the multilayering of the RPE that gives the fundus autofluorescence signal in most cases. And of course, central to that region, you might expect that there would be no photoreceptors, but in fact, there are always a few viable photoreceptors. This slide sequence illustrates the development of atrophy in association with the collapse of a drusenoid pigment epithelial detachment, starting at t equals 0 and progressing over 13 years, where we get a classic window defect on the fluorescein angiogram, as well as flattening and thinning of the retina on the OCT shown below in panel H. A more modern image gives us a little more usable information. Here we can see heterogeneous internal structure of the drusenoid pigment epithelial detachment with retinal hyperreflective foci. And over time, this progresses to atrophy. And it turns out these are two very useful markers for progression to atrophy. In fact, there are 4 very useful markers. The most useful is the presence of a hyperreflective foci. Also useful is the presence of a heterogeneous composition to the RPE detachment, as I mentioned. The height of the detachment is also predictive of progression to atrophy, higher, more predictive. And generally, thinner choroid is more predictive of evolution to atrophy as well. A different way of looking at geographic atrophy is with en-face imaging. I'd like to focus on panel G. We're going to look at that under higher magnification. This is an en-face image done at the level of the inner segment, outer segment junction, and these dark areas represent degeneration of the photoreceptors, both seen en face and in transverse imaging in panel B. And the point I want to make is that there is an asymmetry in the distribution of photoreceptor atrophy around the perimeter of this area of atrophy, which is that central white region. So that on one edge, there's much more photoreceptor atrophy than on the other. And this is a way of saying that we shouldn't expect geographic atrophy to progress at the same rate from all points on the perimeter of the existing geographic atrophy lesion. In fact, there's been a strong attempt to use patterns of fundus autofluorescence to predict the rate of spread of geographic atrophy, with some patterns, such as diffuse trichlet, being associated with a relatively rapid rate of progression of atrophy, and others, such as focal autofluorescence, being associated with a very low rate of progression. So this begs the question, what are we actually looking at when we're looking at geographic atrophy with fundus autofluorescence, or more specifically, what are the sources of increased fundus autofluorescence? Well, this has been done by Dr. Kershaw and her colleagues. The graphs on the top are measuring the autofluorescence intensity, and on the bottom, the corresponding histology. So if we look at panel A and B, we see first increased fundus autofluorescence, and it corresponds to an RPE cell that's engulfed a lot of lipofuscin. This is what I was taught was the main cause of increased fundus autofluorescence. The viable RPE phagocytizing the liberated lipofuscin that was released from adjacent necrotic RPE. And just as you would expect, in the adjacent area where there are fewer lipofuscin granules, there's less fundus autofluorescence. But it turns out that's really not the most common cause of increased fundus autofluorescence. The most common cause is the multilayering of the RPE, which is shown here. And in fact, there are many dysmorphic RPE cells that are not hyperfluorescent. And this probably explains why it is not really easy to predict where the geographic atrophy is going to progress based on the fundus autofluorescence signal alone. In fact, it shows a weakness, I think, in current fundus autofluorescence imaging. The molecular deterioration in the RPE cells is well underway before we see abnormalities in fundus autofluorescence. What would we see if we could? Well, this is what we would see as early signs of RPE dysfunction anatomically. You'd see intracellular stress fibers, you'd see frayed cytoskeletal fibers, and you'd see abnormally enlarged cells. And at the moment, we can't really do this kind of imaging routinely in our patients, but this is done obviously in postmortem tissue. Now, I've spent a fair amount of time on complement and its relationship to AMD pathophysiology, so it's not surprising that there's some thoughts about applying complement inhibition to treating geographic atrophy. Remember, C3A and C5A lead to inflammasome activation with cell death by pyroptosis, and C5B leads to membrane attack complex formation with cell death by osmotic rupture. And so experiments have been done in humans to look at the effects of C3 and C5 inhibition. Avacincaptad, for example, is an RNA aptamer that binds to C5 with high affinity, and it was studied in a large phase 2 trial, and it turns out that it reduces, with monthly intravitreal injection, the progression of geographic atrophy by about 27% administered at a dose of 2 milligrams, and also by about 27% when administered monthly at a dose of 4 milligrams over a 1-year period. Another phase 2 trial was done using pegcetacoplan, which is a C3 inhibitor, and over a 1-year period, the rate of progression when treated monthly was reduced by 29%, and with every other month treatment by 20%. I mentioned to you amyloid deposition in drusen. These are non-fibrillar amyloid oligomers pointed out with the white arrows in drusen. Here we can see mature amyloid fibrils in drusen. They're stained green. And it turns out that amyloid oligomers can activate the NLRP3 inflammasome, working through the purinergic P2RX7 receptor. So if you look on the left, you can see a postmortem human eye with geographic atrophy. Peripherally, there's no ALU-cDNA. Remember, that's what activates the inflammasome, or initiates its activation. But in the junctional zone, where the atrophy is, you see tons of red staining ALU-cDNA. Well, it turns out that there are two classes of small molecule inflammasome inhibitors. One is the nucleoside reverse transcriptase inhibitors, and interestingly enough, they have modified analogs that are antiretrovirally inert. They're called caluvaline, and this also inhibits inflammasome activation. So there's some work being done to develop this as a treatment approach for geographic atrophy and AMD. Well, another treatment that's been tried is human embryonic stem cell-derived RPE. This is work done by Steve Schwartz, this is well known. Here you can see the transplant area preoperatively where the cells were intended to be put as a suspension at the junctional zone. We can see pigmented cells 3 and 6 months later. In the area of atrophy, we don't see many transplanted cells surviving. Another approach for RP transplants been done by Mark Humayun. Here, the cells are grown in a monolayer on a Parylene C sheet that's been nanoengineered. These are stem cell-derived RPE. And here you can see these sheets transplanted into 2 patients with geographic atrophy. Obviously, these are preliminary clinical results. Now, it shouldn't surprise you based on what I said that geographic atrophy not infrequently is associated with choroidal neovascularization. Histologically, about 30% of the time it is. And here you can see the subretinal hemorrhage that's the sign clinically that there's an abnormal blood vessel present. what you might see histologically in such a patient is shown here, where you have a choroidal new vessel lysing its way through Brooks membrane into the sub-RP space, in this case, into the basal linear deposit. Here's a case of Dr. Sarks's with an occult neovascular complex that has a classic component pointed out by the arrow. The patient was treated with laser, developed an RPE tear, and had an area of atrophy that progressed in the margins of the tear. But if you look away from the tear up here, you'll see that atrophy progresses there too. So this is to illustrate the association of atrophy with choroidal neovascularization. Histologically, what you would see and what was seen in this patient is first the type 1 CNV scar, peripheral to which is the area of atrophy of the RP, choriocapillaris, and photoreceptors, peripheral to which is an area of attenuated RP with fibrosis of the choroid. I mentioned to you that RAP lesions are associated with subretinal drusenoid deposits. Here you can see RAP lesion on fluorescein angiography clinically and on ICG angiography. If you look 4 years later, this RAP lesion is associated with atrophy, and this is very typical of RAP lesions. They're commonly associated with the development of atrophy, and that's the main reason that even patients who've been treated with anti-VEGF therapy lose vision when they have RAP lesions. So geographic atrophy occurs in 4 related but distinct situations: the disappearance of subretinal drusenoid deposits in association with basal linear deposit, with flattening of pigment epithelial detachments, and in association with maturation of choroidal new vessels. The efforts to link specific mutations specifically with geographic atrophy have been undertaken and are still in progress. I think fundus autofluorescence technology is important, but probably OCT is the best method to characterize atrophy. And now I want to switch gears a little bit and talk about choroidal neovascularization. This is a sequence in plastic section showing how the CNV progresses through Brooks membrane into the sub-RPE space. But let's look at a clinical picture of a type 1 CNV growing underneath the RP basement membrane. And we can look at the post-mortem histology of the choroid en face shown on the right. And what you can see, and what I want to emphasize, is that anterior to the area of choroidal neovascularization, there's clear-cut choriocapillaris dropout. And that reinforces the idea in my mind that choroidal neovascularization is actually a homeostatic response to choroidal ischemia. And if you look more peripherally, you'll see normal choriocapillaries. If we were to look histologically, what we see in the border zone anterior to the new vessel is this abnormality of the RPE. And I should also point out the thinning of the and collapse of the choriocapillaris. And then in the area of the new vessel itself, which is shown in blue, simply loss of the choriocapillaris, as well as abnormalities in the overlying RPE. And these are easier to see ultrastructurally. This is a work from Dr. Sarks, where you see the tip of the choroidal new vessel growing underneath the RPE with overlying basal laminar deposit, and underneath that, just no patency of the choriocapillaris. Well, as you're all familiar, I'm sure that with hypoxia, we have the elaboration of vascular endothelial growth factor, which is important for tip selection and also for vessel sprouting. And then in the normal course of events, we have maturation initiated by signaling systems such as Ang1 type 2, and we also have the evolution of a stable mature vascular network. And so when we think about where the choroidal new vessels grow, and here's an example of a patient with polypoidal choroidal neovascularization and type 1 CNV, they're growing where they're growing because that's where the VEGF gradient is the highest. And that's not surprising, because if you look at the OCT angiogram of this person, they've got a high-flow CNV at the anterior margin of which is very profound capillary dropout in the choroid. And similarly, if you look at a patient with a RAP lesion, both high and low flow, you might say, well, why does the choroidal new vessel grow between the photoreceptors and the RP? And the answer is because that's where the barrier is to oxygen diffusion between the choroid and the photoreceptors with those drusenoid deposits. Now, even though VEGF therapy is the best thing that's ever been developed for treating CNV, it still has some very important limitations. So the first limitation is efficacy. And you can see that with aflibercept, with ranibizumab, with bevacizumab, there's a ceiling effect where basically with vigorous treatment, you don't usually get more than 6 to, say, 11 letters of visual improvement over 1 to 2 years. The second limitation is durability. So, for example, in the AURA study, which had over 2,000 patients receiving at least one anti-VEGF injection per CNV, the average vision change at years 1 and 2 was 2.4 and 0.6 letters, instead of somewhere between 6 and 11 letters. And why is that? Probably because the patients only received between 5 to 2 injections between their first and second years, as opposed to getting 9 to 10 injections each year, which is what happens in the registration trials. The third limitation is the development of geographic atrophy, illustrated here in a patient in the CAT study with some atrophy at baseline that gets worse by week 104. And in fact, it's quite consistent. If you look CAT, IVAN, and HARBOR, about a quarter, slightly more than a quarter of the patients over 2 years develop atrophy during very rigorous therapy. And in fact, in the 7-UP study, macular atrophy developed in 98% of eyes by year 8, and the area of atrophy was correlated with poor vision. And the fourth thing limiting visual improvement is the development of fibrosis that's associated with the maturation of the choroidal new vessel. So there's a lot of evidence that I've tried to allude to that choroidal neovascularization is actually a homeostatic response to choroidal ischemia. So if you think about this schematic, which is, quite fanciful, but basically the idea is that you get impaired oxygen transport due to thickening and abnormalities in Bruch's membrane and the choroid, and the hypoxia then leads to increased VEGF expression. Then you could see choroidal neovascularization and subretinal fluid as actually a manifestation of imperfect homeostatic response. And if with your therapy or naturally you induce regression of the choroidal new vessels, then you're not going to get the rescue effect with respect to the hypoxia, and you're going to get progression to atrophy. And so this idea would make us say, we don't really want to regress choroidal new vessels. What we want to do is induce maturation of them. And that's where combination therapy might be helpful, and specifically with the angiopoietin Ti receptor system. Now, Ti2 receptor is a transmembrane tyrosine kinase that binds with a cytokine known as angiopoietin-1 and also angiopoietin-2. And when these two elements bind, you get clustering of the Ti receptor with transphosphorylation and initiation of downstream signaling and vascular stabilization. So angiopoietin-1 is a full agonist that, when bound to Ti2, stabilizes the blood vessels. And unfortunately, angiopoietin-2 is a weak partial agonist, which competes with Ang1 for binding to Ti2. And as a result, when it's present in excess, it promotes vascular leakage and neovascularization. So Ang1 basically maintains stable vasculature. If an angiogenic switch is activated, say with hypoxia, Ang2 expression is increased, you get separation of the pericytes from the endothelial cells, and you get destabilization of the endothelium with neovascularization and fluid leakage, which is augmented by the hypoxia-induced VEGF-A expression, which stimulates uncontrolled and abnormal vessel sprouting and immature vessels with structural defects. Conversely, if you block Ang2 signaling so that you increase the excess of Ang1 to Ti2 and block VEGF-A signaling, then you're basically going to maintain pericyte coverage in the endothelium and reduce fluid leakage and maintain a mature phenotype. This is all great. Theoretically, is there any evidence that it actually happens? Well, in preclinical models, yes, there is. Ti2 activation decreases CNV leakage, increases choriocapillaris maintenance. Blocking Ang2 and VEGF-A decreases neovascularization, decreases macrophage infiltration around the lesions. And conversely, increasing Ang2 and VEGF-A expression is not only associated with aberrant angiogenesis, it's associated with severe fibrosis, which is really interesting. Well, it turns out that faricimab is a bispecific antibody that binds Ang2. It binds VEGF-A, and it has a modified FC component that reduces systemic exposure and the potential for inducing inflammation. And these two phase 3 studies, Tenaya and Lucerne, actually explore whether this idea works or not. And interestingly enough, almost 80% of the patients in this study were able to be controlled with injections every 12 weeks or longer. In fact, 45% of them only need injections every 16 weeks, about a third every 12 weeks, and about a fifth every 8 weeks. And the visual acuity outcomes were quite good compared to the active control group, which received aflibercept every 8 weeks. Here you can see the vision outcome over time with faricimab versus aflibercept. Similarly, the dehydration was favorable. Here you can see the OCT changes with the aflibercept with a typical spiking activity with every 8-week injections and a more sustained reduction of retinal thinning with the faricimab. Whether faricimab will have favorable antifibrotic effects or not remains to be seen, and if it does, whether they'll be clinically important or not also remains to be seen. Another treatment that's been proposed for CNV is RP transplants. Here you can see human embryonic stem cells that spontaneously differentiate into RPE. These are selected and grown out to confluency and then grown as a monolayer on a vitronectin-coated polyester scaffold, and this scaffold can be transplanted into the subretinal space of patients. And this was done by Dr. DeCruz and his colleagues and Dr. Pete Coffey in London. Here's the preoperative photograph of the patient with a large submacular hemorrhage. Here's the patient a year later with the RP sheet under the fovea, also seen on the OCT. There is some evidence for ellipsoid formation over the transplant with no recurrence of the neovascularization, maybe a little bit of increase in fundus autofluorescence associated with outer segment phagocytosis, but most impressively, vision improvement from 2640 to 2160 by a year after the surgery, and an improvement in the reading speed from 0 to 8 to maybe 90 words a minute, with normal being 200. Now I want to switch very quickly and briefly go over some mimicking conditions. The first are things that we can actually do something about. So toxicity, hydroxychloroquine toxicity, the safe dose, 4 to 5 milligrams per kilogram, real body weight. Toxicity risk at 10 years is really quite low, but by 20 years, even on the right dose, there's a 20% incidence. Typically, you'll get something like a bullseye lesion with perifoveal atrophy that you might confuse with AMD. Here's the bullseye lesion seen in fluorescein angiography. A more complex mimicking phenomenon is the maculopathy associated with pentastan polysulfate maculopathy, which is a treatment for interstitial cystitis. Patients could present with, very vague visual complaints, but what you see clinically are these subtle perifoveal pigmented lesions and vitelliform deposits that really could be construed as being AMD. And if you look at this sequence of severity, you can see that over time you can develop these regions of atrophy that really do look like geographic atrophy, easier to see with the near-infrared reflectance and also with fundus autofluorescence. Stop the medicine is the treatment. You probably would never confuse AMD with olivopontocerebellar atrophy, even if the patient had a bullseye lesion, because they're also going to have ataxia. Cone dystrophy could conceivably fool you, but the patient's going to have photophobia, dyschromatopsia, hemerolopia. They typically will have vision loss before the macular changes, which is the opposite of AMD. You can have window defects on the angiogram. You can have diffuse RP hyperplasia in the periphery. You also can see optic atrophy, which is not a part of AMD. And this is typically autosomal dominant in inheritance. Here's a person with cone dystrophy that has the attenuation of the vascular caliber at the nerve, temporal atrophy, modeling of the RP under the fovea, and the bullseye lesion. Best disease, as you know, autosomal dominant due to mutation in bestrophin-1, which is a calcium-activated chloride channel or a regulator of the channel. It typically will have normal ERG and abnormal EOG. The egg yolk lesion you would never confuse with any other disease, but when it progresses to atrophy, you might think of it as geographic atrophy. Remember, you have different phases of degeneration. Vision is good when you have the egg yolk. It's good when you have the pseudohypopion that blocks fluorescence. But by the time you get to the scrambled egg phase, the vision is beginning to decline, and eventually you have macular atrophy with profound vision loss, and this is where you could confuse it with AMD, I think. Another complication of Best disease that you could confuse with AMD is coronal neovascularization. Not so easy to see on the fundus picture, but easy to see on the angiogram. Something that really can look like AMD is Sorsby macular dystrophy, except the patients presented at a much younger age. They can have fine drusen, they can have choroidal neovascularization, they can develop atrophy. The angiogram shows the findings you would expect based on the clinical findings, but this is an autosomal dominant inherited disease. due to mutation in the tissue inhibitor of metalloproteinase 3 gene. Here you can see illustrated some of the findings. Here are the typical fine drusen. Here's an example of macular atrophy, and here an example of choroidal neovascularization. And then finally, Stargardt disease, which is the most common cause of early onset macular degeneration. So here patients are presenting as children usually. Fundus often looks normal at presentation in contrast to AMD. Family history may or may not be positive. Of course, they have the yellow-white flecks, the so-called pisiform lesions, dark choroid on angiography, and they can develop macular atrophy. In contrast to the cone dystrophy, the optic nerve and the vessels at the nerve will appear normal. In the recessive form of the disease, typically it's due to mutation in a gene called ABCA4. Here's an example of the phenotypic variability. You can have just a vermilion fundus. This can progress to developing these drusen-like lesions that have a fishtail-shaped or pisiform, so-called, and then eventually can develop macular atrophy, which you could conceivably confuse with the geographic atrophy. Early on, the first finding is loss of the foveal light reflex. Then you can have this abnormal sort of snail slime appearance to the macula, and we see the early fleck formation temporal to the fovea. This is a more classic appearance of the pisiform lesions, and the corresponding angiogram shows that these lesions typically appear as window defects, but outside those areas, you see the dark choroid. And of course, they're going to have abnormal dark adaptation. The dark choroid is due to lipofuscin accumulation in the RPE cells, which is shown here histologically. And the vision, about 60% of them, 2200 or worse, and they're better seeing eye at equilibrium. A quarter of them, though, can have vision of 20/40 or better in their better seeing eye at equilibrium. You can see that it can have a variety of appearances, ranging from just a few flecks around the fovea to many flecks, to profound RP and choroidal atrophy, or just to another bullseye lesion. Now, it turns out that Stargardt disease also can be inherited in an autosomal dominant fashion. This is due to mutation in a different gene. It's the ELOVL4 gene, which has a totally different function from the ABCA4 gene. Here's an example of what the patients can look like. You can barely see the pisiform lesions, but it's easy to see the central area of atrophy. This is another example with the central area of atrophy and the dark choroid on the fluorescein angiogram. Now, the ABCA4 gene is a much bigger gene, the ELOVL4. It has a different function. ABCA4 is the ATP binding cassette that helps to get the all-trans retinal out of the disc into the cytoplasm as all-trans retinol. ELOVL4 is involved in very long-chain fatty acid production. They're both present in photoreceptors, though. So to summarize all of this, when we're approaching the patient with macular degeneration, obviously you start with a history, because that'll help you figure out right away whether you're dealing with typical AMD or some inherited disease. The family history can be very helpful, especially if there's a history of consanguinity and you're talking about an autosomal recessive disease like Stargardt due to the ABCA4 mutation. The exam is fundamental, as always, focusing on the nerve and the vessels at the nerve, the macula, the periphery, and of course extraocular findings like ataxia. Ancillary tests can be quite useful, especially the OCT, and genetic testing naturally. And the treatment can vary quite a bit. For AMD, you stop smoking, you take vitamin and mineral supplements. You might stop taking vitamin A if you have Stargardt disease. You might start taking vitamin A for nyctalopia if you have psoriatic macular dystrophy. Obviously, pharmacotherapy for neovascularization and possibly for geographic atrophy if the phase 3 trials bear fruit, which it seems that they might. And then on the horizon, gene therapy, not only for diseases that are inherited, but even for neovascularization due to AMD, and then possibly also cell-based therapy. Well, I want to thank you all for your attention. I know I've covered a lot of ground, and I hope that you find this lecture a useful introduction to this area. Good evening to everyone.
This does conclude our webcast. You may now disconnect. Everyone have a good day.